Hello, everyone. My name is Rasika Karnik, and I'm an internal medicine physician at the University of Chicago and the medical director of our Long COVID clinic, and so pleased to be presenting to you on behalf of the Council of Medical Specialty Societies project entitled Long COVID Education, Engagement, and Care Management. I will be speaking specifically to mental health symptoms and wanted you to know that this project was also supported by the CDC, and I'm a member of their expert panel. So I wanted to take just a brief second to talk about the long COVID definition. Long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing, and remitting or progressive disease that affects one or more organ systems. And what that means is that, long COVID can present in multiple ways. So there are a lot of symptoms that can be attributed to long COVID. We're going to be focusing on the mental health conditions, but I wanted to take a second to tell you that long COVID associated mental health conditions can be the primary manifestation of your long COVID. It could be secondary to other conditions that are really playing a primary role in affecting a patient's quality of life, or it could be an exacerbation of an underlying medical condition that a patient has already been diagnosed with. So when thinking about mental health conditions, there's, majority of the time the most common one we think about is depression and then generalized anxiety disorder. And that holds true for long COVID as well. Some other conditions that are also associated with mental health related long COVID is sleep disorders, cognitive impairment, obsessive compulsive disorder, PTSD, and fatigue. And patients really describe, and I think that why are we doing this education? And it's really because patients are suffering with long COVID. And so how do mental health conditions actually lead to patients suffering? Is through interviews, we've figured out that really first and foremost, the symptoms cause disruption to their daily activities. And then what happens is their perception that there's a lack of service and treatment options. And what I mean by perception is that actually can happen for patients. And they feel like there's an uncertainty to their illness and the trajectory of this condition for them. And a lack of care of understanding from others in the healthcare system, but also in their life, employers, partners, friends. And so all of these lead to changes in identity, which can be quite debilitating for patients. We also know that depression, anxiety, and suicidality in long COVID patients are associated with financial hardships if this long COVID illness has affected their employment, receiving less medical care than needed, negative experiences defined as quote unquote harmful, dismissive, skeptical, or apathetic with the healthcare system, friends, families, partners, and employers, not having children as well. And those patients that were reported, my doctor did not believe me, were more likely to experience all three of these psychiatric outcomes. And there are supportive factors as well. So folks that used an online COVID-19 support group were less likely to have these psychiatric outcomes, and folks that had access to testing. Thinking about the prevalence of mental health conditions related to long COVID, there was a higher incidence of new mental health symptoms after SARS-CoV-2 than after influenza or other respiratory infections. And we also know that the incidence of COVID-19 is higher in specific subgroups. So people that are from unrepresented race and ethnic minority groups, people with physical disabilities, the LGBTQI populations as well. And there are factors that increase the likelihood of developing post-COVID neuropsychiatric symptoms. That's if you have a pre-existing medical condition, prior history of a mental health condition such as depression, anxiety, stress, or loneliness, individuals hospitalized for COVID-19. Let's talk for a minute about the evaluation and diagnosis. So how do we approach evaluation? First and foremost, we got to rule out reversible causes of psychiatric disease, such as hypothyroidism, B12 deficiency, iron deficiency, and think about some zebras as well when appropriate. Autoimmune encephalitis, Cushing's syndrome, intracranial masses that can cause change in your mood or personality. And consider also that patients are coming to you potentially after experiencing stigma, dismissal, skepticism from other medical providers, and they may be told that their symptoms are psychosomatic, that medical care, we've got nothing for you. And also keep in mind that the traditional psychiatric screening measures, such as the Beck Depression Inventory, rely heavily on somatic symptoms that are common in long COVID patients, in the absence of a comorbid mental health condition, and therefore may overestimate the psychiatric burden. So, for example, if someone's got fatigue, that doesn't necessarily mean that they have depression. The fatigue may be from another condition, such as chronic fatigue syndrome, myalgic encephalitis. The goal of treatment, symptom reduction, quality of life improvement. I think we can provide that, and I know you can provide that for patients. How do we differentiate depression from long COVID? So when is something just related to long COVID versus actual depression? So non-psychiatric long COVID patients, so patients that don't have psychiatric symptoms, commonly experience decreased appetite, weight loss, fatigue, poor concentration, and these symptoms overlap with the DSM-5 diagnostic criteria for major depressive disorder. And so we have to think about how often are you experiencing fatigue? Generally in depression, it's most of the time. But if you have chronic fatigue syndrome with long COVID, it's waxing and waning, not always present. Is there a post-exertional malaise or post-exertional symptom exacerbation? Depression typically gets better with exertion. Is there motivation? In depression, there is anhedonia, guilt, lack of motivation. And in long COVID, the motivation itself is there, but it's limited by fatigue and physical symptom burden. Myalgic encephalitis, chronic fatigue syndrome, symptoms may worsen in the afternoon, while depressive symptoms often improve over the course of the day. And now thinking about how do we differentiate generalized anxiety from long COVID? Long COVID patients commonly experience fatigue, muscle tension, sleep disturbance, poor concentration, and impairment in functioning, all of which overlap with the DSM-5 diagnosis of generalized anxiety disorder. So think about, what is the anxiety centering on? Anxiety as a result of long COVID tends to focus on disruption to work and relationships. And consider the subjective designation of excessive. Does the patient see their responses out of proportion to what they want it to be? And when we think about palpitations, which can be part of generalized anxiety disorder, it's also important to differentiate that from POTS. So POTS symptoms are provoked by physiologic challenge, such as positional change, physical exertion, standing for an excessive period of time, and even food ingestion, hot weather, and drugs that cause vasodilation and that lead to palpitations. However, a non-physiologic trigger provokes cardiac complaints and anxiety disorders. Deeper breaths are more common in POTS hyperventilation, while fast, short breaths are more common in panic hyperventilation. Moving on to treatment, apply general principles for treatment, the general principles that many of us are aware of and that use in our practice. So treatment selection should be guided by a comprehensive assessment of the patient. Use your clinical judgment that incorporates patient preferences, comorbidities, and other patient-specific factors. There's no one-size-fits-all. Balance treatment recommendations or limitations in the event of multiple symptom clusters, and treatment of the underlying medical conditions. So mood and anxiety can be related to or exacerbated by other medical conditions. So focus on those as well. And establish regular follow-up to evaluate response to treatment. Patients need to know they have a partner in this. The most common treatments, so let's talk about non-pharmacologic options right now. So having a positive collaborative relationship with yourself and the patient. And so the patient can feel safe and empowered to contribute to treatment decisions, validation, providing hope, anticipatory guidance, ongoing review of goals that you've made together, dietary and lifestyle modifications, cognitive rehabilitation through speech-language pathologist, individual and group psychotherapy. So all tools in our arsenal. And then we also want to think about the bucket of pharmacologic options. So choosing an agent, there are lots of options. We want to think about the patient preference, their medical comorbidities, attention to side effect profile, and reduction of polypharmacy. Some common pharmacological options, and specifically I'll talk about categories for treating mental health conditions. We've got the selective serotonin reuptake inhibitors, selective norepinephrine reuptake inhibitors, tricyclic antidepressants, bupropion, thinking about low-dose aripiprazole, and also potentially benzodiazepines. Again, think about the side effects for these and how some of them may exacerbate other symptoms, such as insomnia. They can also exacerbate fatigue, so it depends on the treatment choice. And lastly, again, just drawing attention to the fact that their mental health conditions associated with long COVID can overlap with other symptoms, specifically cognitive impairment, sleep disturbances, fatigue, autonomic dysfunction, which can lead to palpitations. So keep in mind those other conditions when thinking about what could actually be the primary driver of symptoms. Thank you so much for your time and your desire to learn more about long COVID. Please visit cmss.org for more information. Thank you so much again.